So, without further ado, it's an absolute joy to be together. I really do feel we are a collective asset together, joined in an interesting topic, one that's so vital at this geopolitical times. And without further ado, I'll pass over to Warren to kick things off for us, and please enjoy.
Thank you very much, Linda, and thanks for inviting me to talk to everybody today. So I'm going to launch straight in. I think we've got a challenge on our hands. I think the kind of starting point really is to accept that we've got huge growing demand. We've got a depleted workforce. Depending on how you want to look at that, that might mean in terms of numbers, but it also might mean in terms of resilience, because everybody's been working harder, doing more, trying to meet demand. Most people's jobs are getting harder. That's the reality. And in some sectors, there's a plan, there's a workforce plan, like for the NHS, there's a workforce plan, but it'll probably take 10 years before that's executed. So we're probably in it for the long haul, I think, before things start to get easier. So because of that, I think the primary objective is, and we touched on this in some of our little teaser videos that we did, we've got to put the workforce first. There is no other option. If we don't have a sustainable, kind of well-sustained, well-resourced, a workforce that still feel like they really want to do this job and they'd rather not do anything else, then services are going to start deteriorating. At the same time as looking after the workforce and recognizing demand, we've also got to do this thing we call trauma-informed practice. We've got to work out how to implement the science of trauma resilience and well-being for the workforce at the same time as meeting all of that demand. And really, that's about removing barriers. It's making it easier for people who've been affected by traumatic stress to get the sort of help they need and to make those services more accessible to people. And then the third bit is we've got to invest in prevention, because actually many of the problems that we're seeing in terms of this huge demand and this huge vulnerability and complexity in the population and the problems sustaining the workforce, that isn't going to change unless we start reducing some of that demand. And actually, most of what we do at the moment is about pathogenesis. It's about picking up the pieces. And actually what we need to do is start focusing on salutogenesis, the thing public health people talk about, which is really about promoting and maintaining public health, keeping people well and healthy. And a lot of this is about investing in the early years. Actually, that's where a lot of the solutions are. So I don't want to speak too soon. I think the beeping stopped, so good work whoever's fixed the beeping. I always have this quote from Desmond Tutu, because I think it sums up the situation. There comes a point where we have to just stop pulling people out of the river. We have to go upstream and find out where they're falling in. Picking up the pieces is not working, really. It's not a sustainable strategy. So we have to find out why people are in pain. So this talk's really about stress. Stress is fundamental to this whole conversation. It's fundamental to human health. And trauma or traumatic stress is a kind of stress that causes injury or wound. So the word trauma means injury or wound. It comes from the Greek language, and that's a kind of stress. And the word stress, believe it or not, wasn't really used in common parlance until about the 70s, when it was popularized by a scientist called Hans Selye, who was an endocrinologist, here's a good pub quiz fact for you. He was nominated 17 times for the Nobel Prize, and I don't think he won it ever. So he was probably pretty stressed by the end of that, I would have thought. Every year, nominated again, but never won. Anyway, he coined the term the stress response. He started applying this term that was used in engineering to human beings, because he was studying studying the impact of stress on animals and humans. And before that, it wasn't really commonly used. It was about an engineering term in terms of the force applied acting against resistance. It was about when things break, essentially. And this word stress became to reflect and represent this wide range of events in the body that occur when the organism perceives threat to its existence or well-being. So it's a response to threat. And that stress can be healthy. It can be tolerable. It can be motivating, actually. It can help us get out of bed in the morning. It can help us, make sure we eat and drink and move, but it can also become injurious, traumatic, or toxic. And that happens when the demands made on the organism exceed its reasonable capacity to meet them. So there's this balance that we have to achieve, this homeostasis, and that's another term that Hans Selye coined, homeostasis. So if we define traumatic stress, we could start with this kind of classic post-traumatic conceptualization. So what does post-traumatic stress look like? So it looks like intrusive memories, avoidance, high levels of physiological arousal and mood disturbances. They're the kind of cardinal symptoms of post-traumatic stress. And following a traumatic incident, the vast majority of people will experience those symptoms. They're normal. They're a normal reaction when we're trying to process and make sense of something bad that's happened. And for about, if we take 100% of people, after a single potentially traumatizing event, 70% of people roughly will move on with their lives and they'll be fine. Those symptoms will fade and they'll be okay. But about 30% of those people, 20 to 30% of people, will have lasting problems. They won't recover. And there are lots of reasons why that's the case. So this is the picture in terms of the classic post-traumatic stress conceptualization. This is from the American Psychological Association. If we think about a slightly more rounded definition, we look at SAMHSA, the Substance Abuse and Mental Health Services Administration of America, and they talk about it as being an event, traumatization being an event or series of events or set of circumstances that is experienced by the individual as physically or emotionally harmful or life-threatening. And it has lasting adverse effects on their functioning. So this is one of those things that I think differentiates traumatic experiences from everyday experiences. So lasting adverse effects. So people say, oh my God, you know, I was stuck on the platform at the train station for 4 hours and I didn't get anywhere. It was so traumatic. Well, it was probably stressful and it was probably really annoying. But if it didn't have lasting adverse effects on your functioning, on your ability to stay healthy, physically, mentally, emotionally, or spiritually, then it probably wasn't traumatic. It didn't create this injury or wound that we're talking about. So that's kind of how I think about the differentiation between tolerable stress and injurious or traumatic stress. And then there's an even better definition. So this is kind of like 3 incredible sentences by Bessel van der Kolk, who probably doesn't need any introduction. But he clearly read Hans Selye's book and was a student of Selye, because he said traumatization, i.e. this injury that occurs, happens when your internal and external resources, i.e. your resilience assets, are inadequate to cope with the external threat. So that injury happens to us when the scales become unbalanced. So if things land on this side, which represents stress, trauma, adversity, tragedy, and loss, and on this side we've got enough resilience assets and ways of adapting, things will stay roughly in balance. We'll be okay. We'll cope. If we've got plenty of things on this side of resilience scales, we will have something to buffer and offset the impact of stress, trauma, adversity, and loss on this side. But sometimes you don't have enough here to balance things out, so you become injured by the stress. Or something so overwhelming and so catastrophic and terrible happens that it lands on this side and the scales tip anyway for a period. And then you've got to find your way back to balance. Sometimes people do psychological therapies like trauma-focused CBT or trauma-focused CBT for psychosis or EMDR, and those things can lighten the load. They can remove some of the distress, help process and contextualize the memories. That helps lighten the load. But sometimes people can't get access to this. So what they got to do is focus on this side of the scales and get busy coping, find ways of coping, find ways of building resilience, find assets, find ways of adapting. And that's where we spend a lot of time with our clients, customers, and service users, is trying to help them build those resilience assets. So after 30 years, this scales analogy, I think, is probably the best explanation I've got for how this interaction between stress, trauma and adversity, and resilience, coping and assets fits together. So I hope you remember that metaphor that we labored a little bit, but it's worth it. I think it'll stick in your mind. So there are loads of different kinds of traumatizing events, potentially traumatizing events. Obviously, abuse experiences are pretty reliable ways of damaging people. They can be physical, sexual, emotional. They can be bullying. They can be online. They can be institutional. Organizations can become traumatized. So if traumatization is this injury caused by stress, the damage caused by stress, organizations can become traumatized. And then they start to become dysfunctional and unhealthy and toxic places to be. So we need to think about that in terms of the corpus, the corporation, you know, the idea of an organization being a body of people. So I won't say much more about that, but if you want to think more about that kind of metaphor and idea, Sandra Bloom writes beautifully on that subject. Other kinds of potentially traumatizing events are loss. And they can be man-made, they can be naturally occurring events, they can be bereavement. And then there are the chronic stresses that I think people don't think as intuitively about. So things like poverty. We know that poverty and isolation as well are both probably accounting for about the same degree or the same amount of premature mortality as smoking. So those are two things that are incredibly stressful over the long term, and they chip away at your immune system. Racism is another form of a kind of insidious stress that chips away at your kind of sense of self and your sense of security. Community trauma, historical trauma, these are things that are collectively experienced, and we have to recognize that we're joined together, and sometimes we experience the harm of stress collectively. They're particularly relevant for organizations and communities. So these events are really common, you know. So this is a study it was funded by the World Health Organization, and they looked at 69,000 people across 24 countries, and they gave people a list of 29 different events that matched with DSM-5 at the time, the Diagnostic and Statistical Manual of the American Psychiatric Association at the time. And they asked people, have you experienced any of these events? And around the world, in these 26 countries or 24 countries, 70% of people on average said they had at least one event that matched that criteria for traumatic events. And 30% of people had 4 or more. So these things are pretty common. It's most people who experience these things. But they also found that same pattern, that the majority of people recover from a single event. But the more events you accumulate in your life, the harder it is to stay in balance. So trauma's got a cumulative impact. The more you accumulate, the harder it is to function, the harder it is to stay well. Really interesting fact from this study, the most protective factor across all of these countries and all of these people was if someone had close social support, they tended to recover. If people didn't have good social support, they tended not to. And we find there's loads of studies that show that pattern. So relationships are the best medicine. That is a fundamental finding across life course studies, across studies of resilience, across studies of trauma. Relationships are the best medicine, particularly in middle age. Actually, in middle age, they have a very predictive effect in terms of how long you're going to live. So just remember that if you're like me in your 50s, you know, make more effort with your friends, I think is the good message to take away. There's another kind of trauma that is particularly toxic, and that is adverse childhood experiences. I've put in brackets developmental trauma, because these are things that happen to children growing up. These are things that happen to children when their bodies are developing, their hormonal system, their immune system, their nervous system, their reproductive system, their brain is developing. And these things can impact their developmental trajectory. And they can also damage and impact the way that children see themselves, see the world, and see other people. So it has a fundamental and profound impact. If children have got enough buffering factors, enough resilience factors to offset the impact of these things, they can come through the other side and stay perfectly well. But what we know from research on big population studies is children that grow up with more adversity tend to have less resilience assets at the same time. That is a pattern that we see time after time. This is not an exhaustive list. It's the list of 10 things that were originally studied by Felitti and Ander in 1998. And since 1998, there have been about 40 plus studies at population level. And the interesting thing is they all find similar patterns. So this finding that there's a dose-response relationship between adverse childhood experiences and poor health outcomes, poor mental health outcomes and poor social outcomes is incredibly stable. And it has been for the last 26 years. It's not going to change anytime soon unless we seriously invest in prevention. In England and Wales, similar patterns to other countries. Half the population say they've had at least one adversity growing up, and 1 in 10 people say they've had 4 or more. So it's pretty common. You know, if you think about a classroom full of kids, it's a handful of children in every class that are going through physical abuse, sexual abuse, domestic violence, domestic abuse, parents with serious problems. You know, this is incredibly common. And what we know is the bigger the dose of toxic stress in childhood, the higher the risk of developing health problems. More people with more adversity have higher risk of cancer, heart disease, inflammatory conditions, mental health problems, being the victim or perpetrator of violence, going to prison, not finishing education, being excluded, being suspended, using more emergency services. The list goes on. And this is such a robust finding that it's completely predictable. And because of that, the only optimism that I can see is that it's also got to be preventable, because we know the pattern, we know the outcomes, we know. You've probably seen the pyramid diagram from the Centers for Prevention and Disease Control that show the pathway from early childhood adversity to premature death. You've probably seen that. Just to reassure anybody that's thinking, oh my God, I've had lots of adversity in my life. This is a population level finding. At an individual level, what matters is the balance between your stress and trauma and adversity and your resilience assets. So one of the things we know is if children have had protective factors, like they felt a sense of belonging at school, or they had other adults in their life that looked after them and loved them and cared for them, or they had a sense of community. These things are really protective. So hope no one's worrying that, oh my God, I've had these experiences and this means I'm going to have poor outcomes. It doesn't work that way. We're just talking about a population level finding. What else do we know? Oh, I should have said, the important thing is, despite us knowing this relationship between the amount of adversity experience and your health outcomes, relationship outcomes, social outcomes, mental well-being, we still don't ask people about it in routine practice. So we still, as part of our assessment in most services, we still don't explicitly ask people what happened to them. That pause was deliberate, by the way. I just wanted that to land, because this is, after 20 odd years of talking about this, I'm still kind of a little bit puzzled that we don't see this as a crucial part of our assessment. In America, in California, and in some other states, they've passed legislation so that GPs and paediatricians get a payment every time they ask someone about their experience of childhood adversity. They see it as a public health opportunity, and they counsel and coach people around resilience assets and recovery processes. So this is a standard question in many states in the US, not so much in the UK. So this is something I think we've got to get better at doing. People with 4 adversities compared with people who have none, this is the English study, were shown to have 6 times greater risk of having an unplanned teenage pregnancy or having caused one. People with 4 ACEs compared with those who had none were 7 times more likely to have been either the victim or perpetrator of violence in any given year, and 11 times more likely to use crack or heroin or go to prison. So we're talking 1,100% greater risk of going to prison if you've had 4 ACEs, according to Bellis and colleagues' 2014 study. So these are massive increases in risk. These are far greater than the kind of increases in risk you see from genetics, actually. When you think about the genetic risks passed on for certain illnesses, some of these are much higher than you see in terms of genetics. But yet we seem to think they're the things that influence our outcomes. But actually, life events, particularly toxic kinds of stress, have a profound impact on our risks of good or poor health outcomes. In terms of mental health problems, there's a huge relationship between childhood adversity and subsequent risk of developing mental health difficulties. This was a table put together by Filippo Veresi, a colleague at Manchester University, of all the best meta-analyses on mental health and childhood trauma. I've crossed out the word disorder because I don't think it's necessary or helpful. People who are depressed do not have a disorder. They have bad things happening in their life, which makes it hard to cope. It's unnecessary. It's a whole other conversation. But anyway, I've crossed out just for dramatic effect. So what we can see is from all of these studies that bring together, they're all meta-analysis. They all bring together the best evidence. There's a strong and proportionate relationship between the extent of your exposure to childhood trauma and your risk of developing all of these mental health conditions. So these findings are often much stronger than the genetic research in terms of odds ratios and relative risk. And what it means is we have to stop asking what's wrong with people. We have to stop trying to diagnose people as a first port of call, and instead start thinking, I wonder what's happened to that person. I'm going to ask that person what they've been through, because there's a reason why their mood's depressed. There's a reason why they're hopeless or suicidal. There's a reason why they're dissociating, or they've got personality issues, or they develop psychosis. There's a reason for that. And usually if you ask the right question, there's a very good reason. Like I never met anybody with paranoia who hadn't been hurt by lots of people. So you can call it paranoia. I would call it hypervigilance to threat for a very good reason. So I challenge a lot of these conceptualizations of mental health issues. What we have to understand is that life events are underneath all of these things. We just have to ask the right questions. It's less intuitive, I think, to understand the link between traumatic life experiences and physical health problems. I think that's less obvious, but the evidence is very good in this area. The branch of science is called psychoneuroimmunology, and it's about the link between our mind, our immune system, and our nervous system. It kind of makes sense. It's how the stress response affects our health. The stress response affects every single system in the body. And in America, the American Pediatric Association are now training their members when they become pediatricians to understand that mind-body relationship. And they issue guidance around the impact on the nervous system, the hormonal system, the immune system, the reproductive system, as a result of stress. So they start to learn about these very powerful links between what's going on between our ears and what happens in the rest of our body. If you want to read a great book on the subject, Gabor Mate's book, The Body Keeps the Score. Sorry, no, that's Bessel van der Kolk. When the Body Says No, by Gabor Mate, is a tremendous book on this subject. This is a study of 2,000 people in Wales, 2,000 people in 2015. And what they found was people with 4 kinds of childhood adversity were twice as likely to be frequent attenders at the GP. They were also more likely to spend time in hospital overnight by 3 times, and 3 times more likely to attend A&E in a 12-month period. They also saw a 4 times increased risk of type 2 diabetes, 3 times increased risk of heart disease and respiratory disease. All of those things are a combination, or are often a combination of lifestyle. So our attempts to feel better, smoking, drinking, drugs, sugar, food, whatever it is, and the impact of stress in terms of inflammation. So we often think, oh, it's our genes, whether we have heart problems or respiratory illnesses or diabetes, diabetes type 2, a propensity to those things. We think it's kind of bad luck. But actually, the science suggests that inflammation plays a major role in all of these things. And with type 2 diabetes, the spikes in blood sugar that happen when someone has a stress response are very hard to tolerate long term. They create problems down the line. So we're starting to understand more about the relationship between stress, the stress response, the HPA axis response, and the impact on our physical health outcomes. Hans Selye said in his original works, every stress leaves an indelible scar, and the organism pays for its survival after a stressful situation by becoming a little older, which is on one hand pretty depressing, but on another hand, it kind of makes you think about how you look after yourself. It makes you think about how you take care of and how you balance your stress in life. The Pediatric Association of America published this paper, and they said chronic dysregulation of the neuroendocrine immune system via the hypothalamic pituitary adrenal axis, i.e. the stress response, has been documented to compromise nervous, immune, cardiovascular, reproductive, and endocrine systems. It affects pretty much every system in the body. So we have to get serious about understanding the role of stress in health, and the role of stress in mental health, and the role of stress in our relationships. We have to get better at mitigating it, both on a personal level, but also on an organizational level, on a national level. The cost to society, the cost to the exchequer in terms of the financial burden, the health costs attributed to childhood adversity in England and Wales, according to 5 sources in this study by Karen Hughes, Mark Bellis and colleagues, was £42.8 billion every year. And most of that is accounted for by mental health problems, heart disease and cancer, directly attributed to the impact of adverse childhood experiences on health outcomes. So, I mean, if there was ever a cost to save argument, an invest to save argument, this is probably it. There are a few studies actually that follow this up now, which are really powerful. So we can both make the humanitarian argument, and we can also make the economic argument now. Part of the issue is that we still treat the symptoms and ignore the cause. This is why I think we need to get better at asking people what's happened to them routinely. Many of the things that people do to feel better if they're in pain is use drugs, use food to feel better. That was the original discovery of the adverse child experiences concept, was Vincent Feliiti's obesity clinic. And he couldn't work out why people were regaining the weight after losing lots of weight and becoming healthier. And when he interviewed them, he found out that most of them experienced some sort of abuse. And actually, food was a self-soothing mechanism. Food was a way of feeling better. So what we do very often is we treat the symptom. Like with obesity, we might treat the symptom with bariatric surgery. And we think it's a medical success story because people lose lots of weight and become healthier. But actually, when you look at follow-up studies, people who've had that surgery, bearing in mind we've taken away their coping strategy, they have much higher rates of mental health issues. They have much higher rates of suicide, and they have much higher rates of other kinds of addictions by about 4 times. So taking away the coping strategy and not addressing the underlying pain is not a solution. It tends not to work. So what we've got to do is find out what's causing the distress and the pain, and we've got to talk to people about what they've been through in their lives, and then we have to try and help them make those connections between what they've been through, their distress, their pain, and their here and now, how they're coping with it. And then what we've got to do is not just take away that coping strategy by trying to get them to stop using drugs or stop eating so much or stop gambling. We've actually got to give them help to address that pain, to deal with past trauma, but also then help them find safer and better coping strategies. Often our treatments are about putting a plaster on or addressing the harmful behavior. But what we don't do is deal with the underlying pain. And that's where I think some of the solutions are. So this whole idea of trauma-informed care, this was evolving. It probably started in the 70s when the Veterans Association in America were campaigning for a diagnosis for their members who'd come back from the Vietnam War, and they wanted to get some treatment for their shell shock. So they created this condition called post-traumatic stress, and they started to get recognized that sometimes life events can cause damage to people. And I think even today, it's still the only or one of the very few conditions in the diagnostic manuals that specifies a life event to be relevant to it. Even depression, it doesn't say a life event can, having bad things happen in your life can make you depressed. It still doesn't say that. The only thing really that identifies it is post-traumatic stress. So following that, there's a whole series of kind of campaigns and lobbies, and eventually it became recognized by the government, and in 2014 they published this guidance. But before that, people were identifying that trauma was a very common problem. Maxine Harris and Roger Fallett published this book in 2001, basically saying that in mental health services, everybody they meet has experienced trauma, but the system they were working in was very medical and didn't really address the needs of people affected by trauma. In 2006, myself and colleagues in the UK published a book bringing together the evidence on trauma and its relationship to psychosis. And then other events happened, but they culminated in 2014 with this very helpful paper being published by SAMHSA, who said an organizational program or system that realizes the widespread of trauma is one that is trauma-informed. It's about understanding there are many different paths to recovery, understanding that it's important for staff, families, individuals, clients to recognize and understand what it looks like, what are the signs and symptoms, but also not just having the knowledge, but then responding to that knowledge by doing something with it, by changing things, changing policy, changing practice, making changes to procedures for both staff and service users. And crucially, not re-traumatizing people. And if we were all together and we were doing a workshop, I always do this exercise where we break off and we go, okay, let's make a list of all the ways that we re-traumatize people in our services and systems. And believe me, that exercise generates a lot of energy, and it can go on for a very long time unless we cut it short, because inadvertently we re-traumatize people every day, and it's baked into some of our systems and processes. And I'm talking about staff as well as service users. So this is something we have to kind of hold a mirror up to ourselves about, and kind of not worry about, it's not a blaming thing. It's about a learning thing. It's about recognizing that maybe we're not always as sensitive to the needs of people affected by stress and trauma as maybe we could be. I've got loads of my own examples as well of how I probably was insensitive to that over the years, but we'll move on. So principles of trauma-informed practice. This is elaborated in the SAMHSA document. These are not just platitudes. These are really carefully thought about. So safety is fundamentally number one in terms of a trauma-informed ethos. So if your staff or your service users don't feel safe, their prefrontal cortex will go offline. They'll go into survival mode. They'll be full of stress hormones. They'll be hypervigilant. They won't be able to relax. And then guess what? You can't relate. You can't trust. You can't connect. You can't think. You can't process. You can't grow. Nothing good happens. If you're not feeling safe, you're in survival mode. It's as simple as that. So safety's got to be the fundamental goal to all of this. And after that, then we've got to think about being trustworthy and transparent. That reduces anxiety and makes it easier to form relationships. Then we've got to think about peer support. Sometimes we need to feel connected to others. Sometimes we need to feel the benefit of community. It's not all about treatment. Sometimes it's about connection as well. Fundamentally, it's about connection. Humans are pro-social creatures. That's why we're at the top of the food chain, because we're pro-social. We cooperate. We need each other. That's how we're wired up. And then going along with that is collaboration. That feels good to people. When we collaborate, we get to solutions that we want to sustain. And it also does something about the power differential. So people that have experienced trauma are often being abused. And abuse is often about the use of power. It's often about power being used against you or used to disadvantage you, or you have your power taken away. And that's a horrible place to be. It's incredibly stressful. So we have to think about how we empower people that we work with, staff and service users. We have to think about how we listen, and we have to think about how we promote choices where choices are possible. And there are choices possible everywhere. Not as many in some places like prisons or probation or, you know, places like that, or police stations. There might not be as many choices, but there's still choices, and we can still be collaborative. We can still be respectful. We can still keep people safe. I've seen it. People do amazing work in very restrictive settings. And then finally, we have to be sensitive to cultural, historical, gender and spiritual issues. Because if we're not, these become barriers. We can be insensitive. We can be obnoxious. We can put barriers up. We can forget about our privilege. So we have to be sensitive to those things and be curious and humble and not be afraid to ask if we don't understand. So these are really important principles. And again, we could talk a long time about these and explore them, but we don't have as much time as maybe we would if we're in person. So I'm going to give you just a couple of kind of thoughts on how I've implemented this in different places. So I do this kind of work in lots of different places, but most, I guess a very good example, a very excellent example is the work I've done with West Yorkshire Adversity Trauma Resilience Programme. So they've got an ambition to become a trauma-informed system, the whole region. All the organisations and sectors want to sign up to this vision of becoming a trauma-informed region by 2030. And that kind of started back in 2019 when Carrie and Amy were leading the programme, or they had an idea anyway, came to me and said, we need someone with some expertise in this field to help and shape and guide what we're going to do. And we have a small coalition of the willing, and we want to know how to tackle this problem. And it's a huge problem. It feels huge at the time. So I've been doing this kind of work for a while, and I've figured out this model, which is basically a way of breaking down that insurmountable task into bite-sized chunks. And I always think about Arthur Ashe, the tennis player, and his famous quote where he said, start where you are, use what you've got and do what you can, right? So you've got to start somewhere. So with this, we had a workshop with a small coalition of the willing, and we set out tables, and each table had one of those themes, one of those layers, and there was a scribe and a facilitator, and people would move around those tables and they'd come up with their ideas, and it was a very mixed group. And people came up with their ideas about, well, what do we do about access to interventions? What are the right interventions? How do people need to access them? When do people need to access them? What does the evidence tell us? Let's think about prevention. What's the global evidence say about prevention, and what have we got locally and what have we not got locally? What are the opportunities? What we could do more of? What's the saving if we invest more in prevention? Then how do we crucially, how do we create a scene of governance that ties together all of these leaders and organizations around this shared ambition? How do we do that? And I remember thinking about Martin Luther King and, his I've got a dream moment. We had to have a collective dream that people cared about. Otherwise, people are going to go off and do their own things. And then we thought about commissioning and how that can sometimes make change happen quicker than waiting for government to make policy, And we talked about what the workforce need, what the workforce strengths are, what the risks were, what their needs were. And we also looked at how we engage fundamentally with community, because if this affects everybody, right? This is about putting the information into the hands of the people and helping them to make good choices and decisions. So we ended up finishing that workshop with a straw man, or a straw person. Maybe that's the best word. We came up with a plan, and that plan was very embryonic, but over the following 4 years, lots and lots of people with lots of talent and enthusiasm and brilliance went off and developed those seeds into amazing work. And this is just a little visual to show that in West Yorkshire, the program's really expanded, and there are work streams on racism, training, workforce development, digital harms, education, reducing violence to staff, organizational approaches, etc., etc. So it's become, it's really flourished. And there have been so many amazing initiatives and projects, from some of the work we did in Leeds Prison to, training all the frontline cops in West Yorkshire Police, amazing project in Calderden and Huddersfield A&E, where they collaborated with youth workers to work with young vulnerable people that were attending frequently, and to mentor and stay with them. And not only have they seen improved outcomes, but they've also saved lots of money as a result of what they're doing. So all of those things are amazing and inspirational. But after 4 years, we had to work out, is the leadership executive, all these CEOs who signed up to it at the beginning, are they all still with us, or are they all going off worrying about other things? Are there other priorities? So myself and Em, who leads the program, went to the senior leadership executive, made up of all the CEOs in the integrated care board and the major organizations in the partnership. And we said, we want to reaffirm your commitment. This is really important. We need to know you're still going to stand by us with this ambition, because we're 4 years in and 2030 is not that far away. And we said, we want all organizations in West Yorkshire to have a trauma-informed ethos and practice. Are you still committed to that? And they said, absolutely, yes, we are. Do you still want all of your staff to have some foundational training, including managers and leaders, in adversity, trauma, and resilience, in the same way that we do with safeguarding? Because if you work with people, you need to know about stress, you need to know about adversity, you need to know about resilience. And they said, yes. Are you still committed to embedding reflective practice and restorative supervision as a way of looking after the workforce? And the answer was, yes, we are. And are you committed to prevention? This was crucial. You don't see the results straight away with this. You see the results over time. So are you still committed to prevention, to moving upstream? And the answer was they were committed to that. And then the final one was about really making this embedded and sustainable at place. And again, the answer was yes. So we went back. I think that was really crucial in terms of securing the future of that program. But if you want to, anything we've talked about today, if you want to get in touch about any of this, you're interested in anything that I've talked about, please get in touch, and we can arrange to explore it in a bit more detail. So I just thought about, what are the things that myself and my colleagues, my team, end up spending a lot of our time with, and what are the things that have worked for us most often in places like West Yorkshire and other parts of the country, and in other countries. What are the ingredients that people say, how do we become a trauma-informed system or organizational service? And these are the things that we seem to spend most of our time doing, but also we seem to be getting consistent results from. And we've got evaluation data to say this is effective. So I call it the 7-part change methodology. And it starts with a collaborative inquiry. So I haven't got time to go into all of these in detail, but I'm just going to give you an overview. So collaborative inquiry is, some people call that ethnographic research, understanding someone's experience and culture. So basically we go into a system, place, organization, and we do a deep dive. We listen, we do a listening exercise, we do focus groups, we do surveys, we do interviews. We find out what people's experience is, and we frame it around a set of questions. And in this case, the questions will be around trauma-informed practice, stress, resilience, burnout, well-being, motivation, health. And we would find out what staff and service users are experiencing, what they think is brilliant and fantastic, what they want more of, what they think are causing the stresses, the pain points, what makes them want to stay in their job, what makes them want to leave their job, what are the next things their organization should do to go on this journey. And then we come up with an insights report, and we have recommendations. And the powerful thing about these recommendations is they're generated by the people. right? So they tell us what their experiences are, and the solutions come from that. So when we play it back to a leadership team, it's very hard to ignore, because if you ask 7,000 people, what's your experience? We want to make it better. You can't really ignore that as a leadership team. You have to act on it. It's fundamentally important. Otherwise, your relationship is damaged. So that's a tremendous place to start. And it leads to the obvious solutions. We then have a plan. The next bit is about action planning. So we've done this with the NSPCC, we've done it with large local authorities, we've done it with coalitions of services, partnerships. Yeah, I'm really excited about that, and it provides really rich information and a great plan. Some settings and sectors have chosen to focus on foundational knowledge first. Some start with that inquiry because it informs everything else. Others want to get right in and start by educating and informing the workforce, which is not a bad plan either. We've been doing this foundational training now for about the last 7 years, and I was working out that we've trained between 10 and 20,000 staff over the last 7 years in this approach. So we've got a lot of evaluation data. And it's basically this idea that if you give people the fundamentals, the science, the knowledge, the information, the evidence, they'll make good decisions. They'll find good solutions. They'll do the right thing. They'll adapt their practice. So I very much see this like safeguarding. It's got to become essential. I think it will become fundamental and mandatory. It's going to become mandatory. The next thing we do is, for some services, we teach people how to ask about adversity, because what we know is if you don't ask about adversity, people don't tell you. People wait a very long time before disclosing abuse or adversity in their lives, and sometimes never do. So we've got to get better at making that a part of our assessment. And I'll say a bit more about that in a moment. The other thing that we know is there aren't ever going to be enough psychologists or therapists. There's a huge waiting list for these things in most areas. Yet we've got lots and lots of people in relationship with people who need help every single day, and they're trying to fulfill and kind of fill the gaps. They're trying to do their job and other people's job, and they're wearing lots of hats, and they're trying to have a therapeutic impact, but might not necessarily have that in their job description, and maybe not have access to training. So our idea is, if we can democratize psychological science in a safe way, we can put psychological techniques in the hands of as many people as possible, that'll be a good thing. And we want to do that for staff, and we want to do it we want to benefit staff by having managers have these skills, but we also want to benefit service users by giving workers these skills. So this is something we've been delivering a lot of recently, which is fantastic, because I see it as a way of reducing burnout, because people get increased job satisfaction, but I also see it as a way of improving outcomes for people, because the people they're encountering have got more skills and confidence and knowledge about the things that are going to help. And we know that 50% of the outcome in any kind of therapeutic modality is down to the relationship. So a lot of what we teach is about relational skills. I think that's a missed opportunity in lots of ways. We, of course, want people to understand the risks of compassion fatigue, burnout, and secondary trauma. So we teach people about what those things are, what they look like, how to measure them, and how to avoid it. And we also teach people about reflective practice. So I think reflective practice is the antidote to some of this occupational stress. But in lots of professions, it's absolutely established, and in other professions and practices, it's just not there. It just doesn't exist. Like in schools, like in policing, in lots of stressful jobs, reflective practice and supervision is just not a thing. Yet we know it can reduce burnout, it can improve retention, and it means quite often studies suggest that it can reduce sickness absence as well. So the opportunity is there, and it's time well spent, and the investment will pay back in terms of workforce well-being. And then the final thing that we do quite often is, let's think about measuring the right things. Okay, what do organizations measure? Well, lots of different things, but what we do know is what gets measured is what gets done, right? So if you're a manager, you know that your goals and metrics are the things you have to pay a lot of attention to, because they're the things you're getting assessed against. So if we're measuring the right things, that's all good. But if we're measuring things that aren't meaningful to service user outcome or to staff well-being, then we're probably missing a trick. So I think measure things like burnout, measure workforce well-being, measure psychological safety, measure relationship quality, measure trust. Measure these things. These things have an impact on outcome. So I think we need to measure these things. There's lots of other things we can measure, and we can measure these things. It's just that it's not well known that these things are possible, that we can measure these things. But we should be measuring the things that affect outcome for staff and service users, not just how many times we do things or how long it takes. I'll just pick the routine inquiry example as one thing just to expand on slightly in the last 10 minutes. What I know is, after 25 years working as a clinician, waiting to be told doesn't work. I've met loads of people over the years that have said to me a version of this sentence. Unbelievably, my nurse practitioner was the first person to ask what the underlying reason for my depression was. It was the first time in 22 years that anyone asked. People, I've had that conversation so many times. You're the first person that's ever asked me this. I've been in these services for 20 odd years. Why has nobody asked me before? That's a reality most of the time. So what's the case for routine or targeted inquiry? Well, in this study that I contributed to, this denial, belief and delay study by University of Sussex and Survivors in Transition, I contributed some clinical case examples from my own practice. And these case examples and this evidence from 608 people was assessed in terms of economics. What does it cost? What's the care cost that people received? And the first startling fact was the average time from disclosure from the start of the abuse for this group of people was 27.5 years. And many of them had tried several times to tell a practitioner or a professional, but weren't heard or weren't given the opportunity. And also the other thing was the annual economic burden for that group of people was £3 billion. And per survivor, it was £4.9 billion. That's just in health costs, not costs to social care or policing or anything else. That was purely health costs. So the economic cost of delayed disclosure is massive, and the human cost is also massive. In terms of disclosure spontaneously versus planned, John Reed and Alan Fraser did a study in 1998 where they observed 100 admissions to their psychiatric hospital in New Zealand, and 8% of people volunteered a disclosure without being asked directly. Then they asked directly the next 100 people. And of those 100 people, 82% of people said, the question was, have you ever experienced any physical, sexual or emotional abuse at any time in your life? And 82% of people said yes. So the disclosure rate went from 8% to 82% purely as a consequence of being asked directly as part of their assessment. And then the final point in my argument in this brief opportunity is Felitti and Anders study, their observational study of 135,000 people at Kaiser Permanente. Those 135,000 people got given an ACE questionnaire as part of their health assessment. Then they were given the opportunity to talk to a doctor or nurse after that about their experience of adversity and how it related to their health or mental well-being. So there was no therapy, it was just a chance to disclose and speak to a professional. In the following year after that opportunity to disclose, that 135,000 people used 35% less visits to their GP and 11% less visits to the emergency room. And when asked, why do you think that happened? Vincent Felitti said, we came to see that asking is a powerful form of doing. It's a therapeutic opportunity. Most people have never disclosed to anyone. They want someone to say, thank you, I believe you. That must have been really hard. Is it still affecting you? Do you need help with that? And guess what? That wasn't your fault. That's a therapeutic act. It's an unburdening, it's a processing, it's a validating experience. So our approach is to teach professionals how to ask safely, how to give professionals confidence in asking. And we've done, this should say 2015 to 2023. We've had 8 independent academic evaluations of the REACH approach to routine inquiry. It increases confidence for staff. It makes it more acceptable and feasible. Service users appreciate being asked as well. It's not just they don't think it's okay. They appreciate it. They think it makes sense. People say, thank you for asking. No one's asked me that before. The consequence is people get the right help sooner. They don't wait 27.5 years before they can disclose. They get what they need sooner. People start to be able to address the underlying causes, not just their distress. They understand where the distress came from. And also we can protect people from ongoing harm. Imagine if we asked a young person in CAMS, have you experienced any childhood adversity from this list? And that person says yes. Well, then you've got an opportunity to safeguard them. And then what we also see is people then, when they join the dots between their past and their current problems, they start to think motivationally about change. We see a really distinct pattern of about 6 to 8 weeks where people are very, very motivated to make changes, which is really helpful. And then finally, the other thing that we see frequently from all of these evaluations is if we talk to parents about their experiences of adversity, either at antenatal visit or in children's centres or in early help services or in social care, they then immediately start thinking about their own childhood, their own experience of being parented, and then they think about their own children. And quite often they'll say to us, oh God, I had no idea, but I'm actually just repeating what my parents did to me. And I don't want that for my kids. I want better for my kids. I think I probably need some help. And that's an amazing opportunity to give people the help that they're asking for. But that for me is a primary prevention opportunity. And we've trained health visitors to do this, who do it at antenatal visits. And pregnant women say, thank you for asking this question. It's really important. What a great opportunity to get help before I become a parent. And then in California, where they're doing this routinely, they get given this conversation. Okay, you've experienced some adversity. Let's look at what you need. Do you know that supportive relationships are a massive benefit to people recovering from trauma? Do you know about sleep, nutrition, and physical activity and how that can help you regulate your nervous system? Do you know about the importance of mindfulness practices and the relationship between your mind and your physical body? Do you know about how beneficial nature can be? Getting into nature for 20 minutes can lower your blood pressure, reduce your stress hormones, help you cope. And we also can give you information about what kind of mental health options you might need if you do need it. So for me, this is a public health intervention. We know from the evidence that if we can prevent adversity in future generations, this is from Mark Bellis's study, we could see potentially 60% less crack and heroin use, 50% less people experiencing violence as a victim or a perpetrator, and half as many people going to prison. But that's the prize if we can prevent childhood adversity. There are lots of public health body reviews of the evidence of preventative programs for reducing child abuse and neglect or adverse child experiences, and there's 4 common themes. Transforming outcomes to the next generation, in line with that last slide, is possible as long as we've got long-term commitment across sectors. And if we do 4 things, first thing is we've got to try and prevent childhood adversity. So there are lots of interventions that help in the early years. We've got to then support children and their families and support their well-being in those early years, and also focus on parenting. There are some studies on universal parenting programs, so where we give parenting programs universally to the whole population, and they tend to show about a 25% reduction in child abuse by making parenting interventions available to everyone, which is incredible. And they also save about $9 for every dollar you spend on those interventions. We also have got to get better at detecting, i.e. asking and finding out that someone's been through adversity, and then mitigate the impact, so give them the right help sooner. And then finally, we've got to get better at promoting resilience across the life course. Let's help people stay well. Let's help people recover and look after their well-being and preserve that health. And that's not as common as we might like. So my recommendations in the last 2 minutes: we need cross-sector commitment to this agenda, not just trauma-informed practice, but prevention-focused practice. We need to increase awareness about trauma, adversity, resilience across all sectors. And I think it should be mandatory knowledge if you work with humans. And we should also make this information available to the public, because I would have liked this knowledge at antenatal classes when I was about to become a parent. Train professionals to ask about adversity, give them the skills, because people don't feel comfortable asking. They worry about opening a can of worms. And I always say, look, there is no can of worms. The person you're asking already knows what's happened to them. It's really just a feeling of anxiety that you might get it wrong, but we can help you with that. And then we'll also improve access to trauma-focused therapies, because 20 to 30% of people aren't going to get better unless they get them. And currently it's really difficult to get access to those things, but they're reliable, powerful technologies that are just scarce and unavailable. And then finally, put the workforce first. There is no service without them. And on a final note, in my last minute, relationships are the best medicine, and resilience is the antidote to toxic stress. The Harvard Grant study of life course development showed over 90 years, looking at a whole group of people and their offspring, that relationship satisfaction was the best predictor of how long they lived and how happy they were. And that was more powerful than genes, IQ, social class, or diet. Relationships are the most powerful predictor. In terms of what helps you recover from PTSD, relationships are the best predictor of recovery. In terms of what predicts outcome in psychological therapies or psychosocial interventions, quality of the relationship predicts who gets better. So that means that if healing relies on the relationships, then we've got to look after the people looking after the people, right? So the workforce first again, otherwise they'll have nothing to offer. 50% of the outcome depends on the quality of the relationship. So we have to look after the people. And when people used to go to Irving Yalom, who's a famous American psychotherapist, go to his university classes, you know, young psychiatrists and psychologists learning to be psychotherapists, they always ask him the same question. What's the secret? What's the secret to helping people recover from trauma, from stress, from pain? And he said, it's very simple. It's the relationship that heals, the relationship that heals, the relationship that heals. So on that note, I'm going to stop, and maybe there's time for questions. I'll do my,
Brilliant.
I'll give you my contact details just in case you want to.
Well, first of all, I'm going to repeat a comment in the chat. Wow. Okay, I think it was Claire who put that into the chat. I knew this was going to be absolutely crammed, not just with information to inform, but also what I really liked about this is it gave us something to grasp in terms of what we can do next as ambassadors for this. Can you stay for a few minutes? Can we check in with a few questions? I've got some in the chat, but before I go to the chat, would anyone from the floor like to make we've had some marvelous observations in the chat if anyone wants to check. I know some people will have to leave. Please, we can make the recording available, but if you'd like to ask a question, can I open to the floor? Lucia or Lucia, welcome.
I'm a health coach, and it would be interesting actually to sort of be able to sort of raise that question in an appropriate manner. I have got some patients that have got trauma. I've just seen one this morning and referred them on to the appropriate EMDR services and therapies and things like that. But I'm hoping that I have handled this patient very well and, you know, empathetically. So more training would be fantastic. Thank you.
Fabulous, Lucia. I almost can tell that you have, and it links to something that I'll pick up from a chat question, one that you might want to respond to, is what services and professions should be asking that routine inquiry about ACEs? And there's already someone who's on this call who's a health visitor who's had the training and really swears by it. So Warren, any thoughts on that?
Yeah, so I would say anybody that's got an ongoing relationship with people seeking help, right? So in America, they talk about screening, and there's all these arguments and questions, reasonable questions about ethics in screening, but I'm not advocating screening. I'm advocating asking people that are seeking help, right? So if someone's coming to me to ask for help, or to you, or you're caring for them, and therefore you're going to do an assessment which helps you determine what are the factors that are leading to their distress and discomfort and illness, and what are the factors that might help. That's what an assessment is. Then, because we know that this factor of adverse child experiences and stress is so fundamental and common, and it causes so many of the problems we're dealing with, then it's clearly obvious to ask about adversity. So if you've got an ongoing relationship with somebody, and if you can conduct some kind of assessment, then you should probably be asking. But what we also know is if professionals don't have any training how to do that, they tend not to want to do it, because you've only got to look at health visitors actually who do an amazing job and have been some of our most successful advocates in this approach. My experience as a parent was that the health visitor who asked me and my wife about domestic abuse, which was one question, was incredibly uncomfortable about asking that question. And that's not because she wasn't really good at her job. She was amazing in so many ways, but she was really uncomfortable at that question. And it turns out that actually she hadn't had any training on how to ask about that, how to ask that question or position it or to respond to it. So as a result, it made her feel really anxious. So she kind of went, oh God, I've got to ask this question. I'm really sorry, but oh, you're a nice family. Oh, maybe I'll not ask it. Oh, well, go on, I'll ask you. And I'm like, do you want me to leave? Oh yeah, good idea. You know, so it was really awkward, and it really was because no one had explained what words to use, how to set it up, how to respond to what comes next. And as a result, she was quite stressed. So we do recommend some training, but also that the service talks about where does this fit? Where does this fit in what we do? and how is it best positioned, and how we're going to record it, and how we're going to support our staff, and what do we do next if people want some sort of support. So
thanks, Warren. And there are some related questions. I think you've picked them up. So the fact that people fear asking the question because they won't know what to do with the information when they get it. I think you've started training is, I think, the answer that we've had here. And we've got some incredibly inspiring chats. You know, we've clearly got a lot of people very motivated to do more with this presentation, which is brilliant. Carl, your question, please. Carl Jeffrey.
Sorry, it's Carly. Sorry.
Oh, Carly, I
That's
do
fine.
apologise.
That's okay. Don't worry. That's fine.
Cheers.
And it was me that put in just in respect of health esteem.
You did.
I work in health esteem. I just wanted to share an experience from my experience as a health visitor during COVID. I went. I'm a qualified nurse. I went back into A&E during COVID, and just to pick up on the points you were saying, Warren, about really exploring with patients their background. There was a chap who I was looking after who came into A&E who was known to the A&E staff as a regular attender. He was an alcoholic, so he was coming in, he had had an episode, he was needing treatment for that. Because we had the time and the kind of capacity, believe it or not, during that first wave of COVID, I sat with him and just spoke to him, using my kind of health visiting assessment skills. And like you said, just heard about all of his aces in life. He grew up in a house with alcoholic parents who weren't present, you know, and there was a real then understanding of why he was where he was. And I kind of spoke to some of those colleagues that I had in A&E, and they were a bit like, oh, you know, we never realised, you know, this guy comes in all the time, they treat him, you know, and that could be down, like you said, to training, time, to not actually, I was privileged that I was able to sit with him and actually have that conversation. And we know in, you know, normal current times that you don't always get that, do you? But yeah, it just really stood out. And I think it's quite a good example of where, you know, just giving that patient that time to actually discuss their background and just gives you a better understanding of where people have. And I think, like you said, you know, I think definitely that's something we're really good in health visiting, that everybody has a story and there's a reason to why they're here, and for us not to make judgment on that and just to have a clear understanding. So just wanted to share that.
That's brilliant, Carly. And what you just said was so important, because for me, I was listening to that story, I was thinking that would change completely how I would relate to that person. If I knew that about this person's background, it wouldn't be about what's wrong with them anymore, why they're here, why they're bothering us. It would be about, wow, what do they need, right? What does this person need? Why are they coming here? What is it they really need, you know? And it could change the conversation away from the, you know, the kind of the cut on the head, or the, you know, the nondescript problem they keep coming back with, to how's that affected you? How have those experiences affected you? And maybe you get to maybe it takes 10 more minutes, but maybe you get to the bottom of it once and for all, you know. And we've certainly seen that with health visiting. We've also certainly seen it in GP practices as well, you know. People come time and time again, but as soon as you start having the right conversation, the complexion of the conversation changes completely, and the way staff see that person changes as well. You know, there's an increase in compassion, actually.
Right, we have 2 more questions, and I think we may need to close it down a little, but I'll just, in the housekeeping, tell people how they can continue to have the conversation with you, Warren, because I know you want to do that with people who've been inspired by this, but also how we can get all the information to you all. So if I can, Kirsten and then Claire. Kirsten, your question.
Hi Warren, we've met before. I've been fortunate enough to attend some of your training with the VRN. So I just wanted to touch basically on training. So as you know, I'm a student nurse as well as an assistant practitioner, and after the training that I attended with yourself last year, it really had me reflecting on how nurses are trained. Now, just a few months from qualifying, I've reflected back on the course and thought, actually, the new nurses that are going out there, we are the ones that have the ability and the power to sort of get the motivation going and get behind this change. So it really got me thinking as to how can this happen. So after months and months of hard work and working alongside the university, they've actually now agreed to include trauma-informed training within the curriculum. So it's actually at the university I attend, it's actually going to be, and they're looking at not only rolling out with nurses, but all of the health faculty going forward. So, and that's from attending your training. So thank you very much for inspiring me.
Amazing. Congratulations, that is quite something. And you know, in the future, maybe this will become like everybody will be learning this when they're training. And drop me an email. I'd love to know more, because it sounds really exciting what you're doing, and maybe lots of other people can learn from how you managed to persuade the powers that be that this should be.
Do you know, I just provided them, I was very well supported by the VRN to do it, but I just provided them with the evidence. And I think once you've got the black and white evidence to show, actually, you know, what you've said is you want us to be this type of nurse, well, this will support that.
Yeah, absolutely.
It's you know, it is quite black and white when you look at it like that. So thank you.
Thank you so much. That's really uplifting. Thank you.
That's brilliant, Kirsten. Thank you. Excellent. Really, really amazing. And it'll inspire all of us. It sort of takes you back to that call to action from Arthur Ashe, I think. And final question to you, Claire. I think we could go on a lot longer, Warren, but I and as I said, I can see how I can keep this conversation going out with. But Claire.
Thank you so much. Just really quickly, and it sort of follows on what the lady was just saying there, which is fantastic. Outcomes, measurements, metrics, that's what I'm hearing all the time. I'm trying to change the system, but people want measurements and blah, blah, blah. So how do we know, where do I find out what the right things are to measure? Have you got me down somewhere?
Well, it depends what you want to achieve and who you're trying to convince, right? So this is the thing, everything from like we're doing a randomized control trial of trauma-informed practice in secondary schools in England, in 70 secondary schools. That's kind of the kind of level of evidence you need to change educational policy and, you know, to get the government to listen. If you're trying to convince a service, an organization, a coalition of something, you might need a different kind of evidence. You know, you might need more practice-based evidence. You might need more service user testimony. You might need more economic evidence. It kind of depends what you're trying to achieve. But drop me a message. I'll see if I can. I'll see if I can help in some way when I know a bit more about what you're trying to work out. Yeah. Absolutely.
Thank you very much.
Brilliant.
Thank you.
I'm sure, Warren, it pains me to have to close this evening, but it has been an absolute joy. I knew you wouldn't disappoint, and not only have you shared some information, but I think you've dropped us a call to action there, really, haven't you, in terms of what are we going to do with the assets we've got. And I think people here on this call, some have already done it and are inspiring us to do more, and I suspect other people will reach in. I'm sure you would all agree with me, it's more than delivered in terms of information. We have the generous leadership and generous thought leadership from Warren in the slides, which I know you've agreed to be happy to support. We've got the recording today, which will be made available to you. We will also synthesize from the chat, so if any more people want to add to that or put Q's and A's in, we will collect them, and I know Warren will work behind the scenes to give everybody a bit of a rounded answer to that, which again is so amazing. I've just loved it. I wish every day, and actually just it's my birthday today, so this is a fantastic present for me in terms of information you've shared and inspiration you've shared. So thank you all again for joining, and on behalf of everybody, Warren, a huge thank you today for that excellent presentation. Thank you.
Thanks for doing this on your birthday, Linda. Thank you.
It's a joy. It's a pleasure. Excellent. Thank you, everybody. Go forth and do more with all of this information in the amazing roles that you all play. And thank you for joining. Look out for the next Festival of Leadership and Learning. More where that comes. It'll be hard to beat this one, I have to say, but if you can and you see them go out, spread the word. We want as many people to join our community of interest.
Thanks, everyone.
Thanks, everybody.